I'm Candace Johnstone, a professor of radiation oncology at the Medical College of Wisconsin, here to do some myth busting to give you the facts and the data for 8 gray in a single fraction. We'll do some fact versus fiction questions to make this a little more interactive. We'll go through the answers in the context of the data, but these are all things that I've had pointed out to me over the course of my career and when I lecture on this topic. The first is fact versus fiction. Response rates with multi-fraction regimens are higher than with 8 gray in a single fraction. The second, fact versus fiction, multi-fraction radiation is more durable and thus preferred for good prognosis patients. Fact versus fiction, single fraction radiation is inferior when there is a soft tissue component. Fact versus fiction, pathologic fracture rates are higher with single fraction radiation. Fact versus fiction, the data doesn't apply to spine or pelvic treatments. Fact versus fiction, bone recalcification favors multifraction regimens. Fact versus fiction, the need for retreatment is higher with single fraction radiation. Fact versus fiction, multifraction regimens provide faster pain relief than single fraction radiation. And lastly, fact or fiction, single fraction radiation causes more acute side effects. So on to the data. Many of you know that 34 randomized controlled trials demonstrate the equivalence of 8 gray in a single fraction to multifraction radiation in uncomplicated bone metastasis. This equivalence has been demonstrated across any outcome that has been prospectively studied. So let's look at the first question. Fact versus fiction. Response rates with multifraction regimens are higher than with 8 gray in a single fraction. This is false. Here are the 3 largest trials of fractionation. And you can see each of these trials has about 1,000 patients. Note that the RTOG trial published by HeartCell was limited to favorable prognosis patients, those with breast or prostate cancer and bone-only metastasis. Each had slightly different multifraction arms, but compared them all to 8 gray in a single fraction. And just a note that 24 gray in 6 fractions is biologically equivalent to 30 gray in 10. The BED for an alpha beta of 10 is similar, as is the EQD2. So you can see here that the response rates are all equal between the single fraction and multifraction arms. What is different is the retreatment rate, and we will get to that a bit later. So I'm going to ask you this question. Do we give biased presentations in our mind to our trainees, to our patients? Do we tell them that on average, your pain score will decrease equally regardless of the regimen? Or do we tell them the retreatment rates are different? So this is food for thought. The second fact versus fiction. Multifraction radiation is more durable and thus preferred for good prognosis patients. Well, we know this is fiction. It's a myth. 2 of the randomized studies actually followed their patients long enough to really comment on this. In Norway, patients were followed until death. About half of patients were alive at 28 weeks, and 32% of patients had more than 1 year survival. And when they looked at only those patients who lived more than 1 year, there were no difference in any of the outcome metrics. Not an outcome metric, but the single fraction group did have a higher retreatment rate at 27% versus 9%. However, the time to retreatment was equal between the arms, and 50% of patients required re-irradiation within 4 months of their initial treatment. In the Dutch bone metastasis study group, they performed a subgroup analysis of only patients who were enrolled in the randomized trial who survived longer than 1 year. The response rates were equivalent at 85 and 87%. These were not significantly different. In addition, the time to response to radiation was equal in both groups, 4 weeks, whether they received a single fraction or multi-fraction radiation. Also, the duration of the response was equivalent, and they gave both the mean duration of response and the median duration of response, and you can see the mean response duration was 29 and 30 weeks, and the median was 35 and 42 weeks. Not significantly different. When they looked at their patients, again, all the patients who survived more than 1 year, the time to progression was equal. On average, patients had progressive pain at the treatment site in 17 or 18 weeks. And the presence of progressive pain at the treatment site was the same proportion in both groups, 53% of the multi-fraction group and 55% of the single fraction group. Not significantly different. To put this together in the long-term survivors in the Dutch trial, response rates equivalent, time to response equivalent, duration of response, mean and median were equal, progression of pain equal, and time to progression also equal. And you'll note also that the time to progression of 17 and 18 weeks is consistent with the study from Norway, which showed that the need for radiation became apparent at 4 months, which is approximately 16 weeks. Fact versus fiction. Single fraction radiation is inferior when there is a soft tissue component. So to step back, what defines an uncomplicated bone metastasis? The 35 randomized trials mostly had the same entry criteria of an uncomplicated bone metastasis. And the entry criteria all were very, very similar. No impending pathologic fracture, no spinal cord compression, no neuropathic pain, but a soft tissue component was considered an uncomplicated bone metastasis, and patients with soft tissue components were treated on this trial. So the data does apply to them. Fact versus fiction. Pathologic fracture rates are higher with single fraction radiation. This is fiction. When you look at the meta-analysis, which comprised about 5,600 patients on 25 trials, the rates of pathologic fracture were equal. Single fraction 3.3%, multi-fraction 3%, not statistically different. Fact versus fiction. The data doesn't apply to spine or pelvic treatment. This is fiction. To demonstrate that these patients were well represented, I've given examples from the 3 largest trials. 34% of patients were treated to the spine in the bone pain working party trial, 14% to the cervical or thoracic spine, and 28% to the pelvis or hip. So clearly these patients were well represented on the trial. In the Norwegian study, 40% of patients were treated to the spine, 20% to the cervical or thoracic spine, and 25% treated to the pelvis. Similarly, for the RTOG trial, the number of patients and the percentage of patients with weight-bearing and non-weight-bearing bones were equivalent and well represented in the trial. I want to delve a little bit into the RTOG response rates. On the left is a summary slide, but we'll blow that up so you can see it a little better. When you looked at their stratification variables, the response rates in terms of complete, partial, stable, or progressive pain were similar regardless of stratification variables. Here is the data for the number of painful sites, either solitary or multiple, and you can see the p-value is non-significant between single fraction and multi-fraction radiation. Similarly, for weight-bearing or non-weight-bearing bones, the response rates and the breakdown were similar in both groups, regardless of fractionation. When you look at the worst pain score prior to treatment, the response rates were similar between single fraction and multi-fraction radiation. One category was an outlier. It's a very small subgroup. But in all other subgroups, regardless single fraction or multi-fraction radiation, 21 to 30% of patients had stable pain, so no improvement, but no worsening. Between 5 and 16% of patients had progressive pain, regardless of fractionation. So giving multifraction radiation does not guarantee a pain response, and the results are similar between 30 gray in 10 and 8 gray in a single fraction. Fact versus fiction. Bone recalcification favors multifraction radiation. There's not a lot of data on this subject, but there was a prospective randomized trial of approximately 100 patients with multiple myeloma that showed no differences in multifraction and single fraction radiation between the complete response rates, partial response rates, and recalcification of treated bone. About 34% of patients in both groups had recalcification of the treated bone, and there was also no difference in quality of life. When you look at recalcification rates stratified by response rate and destruction of bone, you can see there was no difference. Here, the control group was the 30 gray in 10, and the experimental group was considered 8 gray in 1. When you look at pain scores and opioid use, no differences between multifraction and single fraction radiation. Fact versus fiction. The need for retreatment is higher with single fraction radiation. So this is a little bit of a trick question because I put the need for retreatment, which in my opinion is fiction. Retreatment rates are higher with single fraction radiation, but about 55% of patients progress with pain regardless of fractionation, so the need or the presence of pain after treatment is the same in both groups. Here we look at the Dutch bone metastasis study group, and you can see the time to progression of pain increases over time. And you can see that about 50% of patients have progressive pain at about 16 weeks, which is the average. Fact versus fiction. Multifraction regimens provide faster pain relief than single fraction radiation. This is fiction. Clearly, in this graph, which demonstrates the probability of response and the weeks since randomization, they're exactly overlapping. So the time to response is equivalent between single and multifraction regimens. Fact or fiction? Single fraction radiation causes more acute side effects. This is fiction. In fact, most of the data suggest lower side effect profile with single fraction radiation. Here's the toxicity chart from the RTOG and a summary, which shows no difference in the acute or late toxicity between single and multifraction radiation. This is the report from a study of painful vertebral metastasis, single fraction versus multifraction radiation. You can see here that grade 2 to 4 acute side effects were double in the 30 gray and 10 fractions compared with the 8 gray in the single fraction. The number of patients with late toxicity is small, but they don't seem terribly different. This is a paper that also looked at quality of life, and it actually stratified by survival. So the top graphs with the dark black, noted here, are the patients who survived the longest. And what I want to draw your attention to is here. These are the patients who survived the shortest duration after palliative radiation. And these are the subgroups with a significant difference in single fraction versus multifraction in terms of quality of life. And so for those patients at the end of life, multifraction regimens may decrease quality of life more than necessary. The next two slides demonstrate patient-reported outcomes that were prospectively collected using standardized and validated questions. The first table shows that there's no difference in mean change in total score, mean change in pain score, mean change in function score, or symptom score between multifraction and single fraction radiation. This is just a graphical representation of those same facts and shows the difference between baseline, which is the striped area, and follow-up, which is the shaded area. In all groups, symptoms decreased after radiation, and there's no difference in patient-reported outcomes between the single fraction and multifraction scores. I've been asked if there is a field size limit to single fraction radiation. Many people recall vaguely that there were trials of half or hemi-body radiation. The hemi-body radiation could be delivered to the upper half of the body, the lower half of the body, or the middle portion of the body, depending on the region causing the pain. Most patients in these trials actually had extremely rapid pain relief, 24 to 48 hours, and it was well tolerated. The dose was given 8 gray to the mid or lower hemibody, but 6 gray to the upper hemibody because of lung toxicity. Thus, whole pelvis, multiple vertebral bodies are safe and without significant toxicity, and I would say the field size limit is the hemibody, upper, lower, or mid. Because patients will, on average, recur with pain about 4 months after radiation is delivered, retreatment has been studied. The largest study of retreatment was a randomized trial from Canada that the RTOG participated in. Retreatment is safe and effective and less toxic when using 8 gray in a single fraction, compared with 20 gray in 5 fractions. Some exclusions do apply, and you have to look at the inclusion criteria carefully. Various prior fractionation regimens were allowed for entry into the trial. However, if there was bowel in the field, then they could not participate in the trial if their first course was 24 and 6, 27 and 8, or 30 and 10, due to concern for bowel toxicity. There had to be a minimum of 4 weeks since the end of radiation, and they were randomized 8 gray in 1 to 20 and 5. The exception was if they were randomized to 20 and 5 and the site was the spine or whole pelvis, they were treated with 20 gray in 8 fractions, again out of concern for toxicity. When you look at the response rates, you can see here that the overall response is equivalent, 45% and 51%, regardless of fractionation. The complete response rates were similar, partial response rates similar, not defined similar, no change similar, and progression of pain similar. No significant differences. So the conclusion from this trial was that 8 gray was not inferior to 20 and 5. There was no difference seen in the response rates or the quality of life, and the mean follow-up was 12.3 months. However, there were more side effects with 20 gray in 5 fractions, and these side effects included anorexia, vomiting, diarrhea, and skin reaction. There were no cases of radiation myelitis. There was no difference in infield pathologic fracture, spinal cord compression, or quad equinus syndrome, and the overall survival rates were similar. I'm just going to summarize the meta-analysis because this included 25 randomized trials of single fraction versus multifraction regimens. 5,600 patients enrolled on these trials. The overall response rates were equal, about 60%. The complete response rates are equal, 23 to 24%. There was no difference in pain medication requirements. The rates of pathologic fracture were equal, about 3%. When you look at the meta-analysis, because they had different outcomes, 3 trials demonstrated acute toxicity was less with single fraction radiation. 1 trial reported that the pain flare was worse with single fraction radiation, and all trials demonstrated the costs were significantly lower for single fraction radiation. What is different? Retreatment rates are different. As we've seen before, single fraction radiation retreatment rates are about 20%, and multifraction radiation retreatment rates are about 8%. But this doesn't suggest whether you need reirradiation. It just says whether they were done, because many of these trials did not predict that this was going to be the case, and so did not stratify for this upfront. So again, when we look at the 3 largest trials of fractionation, we can see here the response rates are the same, which I think should be the focus of our conversation. But more often, we focus on the retreatment rate, which are different. The cumulative meta-analysis, again, showing a forest plot with retreatment rate higher with single fraction radiation. But I want to ask you this question. Is retreatment a reasonable surrogate? So I want to ask, who remembers a time before IMRT and SBRT? Who remembers 2D simulation and planning? This is the era when almost no one retreated after 30 gray in 10 fractions. So these trials and the retreatment rates are biased because of the prevailing thought about toxicity and safety and efficacy of retreatment. So with that, I'm going to give you a few cases. I'm going to run through them relatively quickly. This is Mrs. T. She's a 61-year-old woman who presented in 2016 with severe back pain with a left breast mass for 10 or 15 years, a CT with a pathologic fracture at L4. She had invasive ductal carcinoma, grade 2, ER-positive, PR-positive, HER2-negative with a Ki-67 of 10%. This is a picture of her L4 lesion. I treated her with 8 gray in a single fraction in 2016. Her most recent imaging was June of 2021. She's still alive now in 2023. But as of her last PET scan, which was June of 2021, she had no evidence of disease. She continues on the same regimen she started, letrozole and palbociclib. Her L4 lesion has been controlled now for 8 years. However, there's a little twist to this story. In February of 2019, she presented with progression of her right fourth rib lesion. L4 still had no FDG uptake. So what did I do? I treated her with 8 gray in a single fraction in April of 2019. But lest things be predictable, because prior response may not predict future response, she had restaging approximately 1 year later, and that right fourth rib lesion was very hot and FDG avid, whereas the L4 region was completely controlled. So at that point, I treated her with SBRT 30 gray in 30 gray in 3 fractions of 10 gray. And today, she is still no evidence of disease, completely controlled on her stable regimen. Now, how I think about this is the biologic sensitivity may vary over the course of a patient's disease course. She might have had more sensitive clones at the initial presentation than she did in 2019 when I initially treated her with 8 gray in a single fraction. So prior response doesn't necessarily predict future response, good or bad. So this is another case to demonstrate soft tissue mass treatment. Mrs. C is a 49-year-old woman diagnosed in 2019 with an early stage triple negative breast cancer. She did not receive any adjuvant treatment, and in April of 21, she presented with severe chest pain, which was due to this 5 centimeter soft tissue mass invading the sternum. A biopsy was grade 3 triple negative IDC. She received a single fraction of 10 gray in April of 21, and she had pain relief starting within a few days. By 2 months, she had no pain and a completely flat chest and resolution of the soft tissue mass. She did receive 4 cycles of Taxol chemotherapy, and then in November of 2021, 6 months after her treatment, she still had no recurrence of the soft tissue mass and sclerotic bone. So I think in summary, we can talk about the fact that single fraction radiotherapy for bone metastasis is clinically effective, time efficient, cost conscious, and still underutilized in the United States. And I'll draw your attention to the fact that this was published in 2009, and we're still talking about this now in 2023. So I want to ask the question, why? I have some ideas. I've given them in previous talks. But here's an interesting fact. As you know, SBRT has become more common. And so the RTOG started a study, RTOG 0631, enrolled 339 eligible patients and randomized them to 16 or 18 gray in a single fraction versus 8 gray in 1 fraction. And they used the NRPS scale to determine pain response. You can see the baseline pain scores were similar. At 3 months, the baseline scores were similar. and the pain response rates were actually higher for external beam radiation. So, interestingly, what the authors concluded when they presented this data was not that this was a negative trial, that single fraction radiation with standard external beam is good enough, but maybe they didn't use enough dose. I guess we are radiation oncologists after all. But I'd encourage you to try single fraction radiation, at least for all your uncomplicated bone metastasis, for two reasons. One, it works. The more you use it, the more you'll fall in love with it. And I do think you'll be impressed. And if we as a society could treat all of our uncomplicated bone metastasis with single fraction, we would have accomplished a lot together. And I'll leave you with a final thought. To me, these next two trials that I'm going to talk about are the most compelling reasons to use single fraction for uncomplicated bone metastasis and hypofractionated radiation for palliation. These two different studies were two different institutions and looked at the amount of the last 30 days of a patient's life spent receiving radiotherapy. In the first trial, you can see that 14% of patients spent 11 to 15 days of their last month of life, and 21% of patients spent more than 16 of their last 30 days of life receiving treatment. So that's 35% of patients coming in more than 1/3 of their last month of life to receive radiation. The table on the bottom divides things up in a slightly different way, but if you look at the number of patients or the proportion of patients receiving radiation in their last month of life, 80% of patients spend more than 40% of that last month coming for radiation treatments, which to me needs to change. This demonstrates significant numbers of patients are spending most of their last month of life receiving radiation. And while I do believe that single fraction radiation can be used in good performance status patients with good prognostic life expectancies, I think it's absolutely imperative to use single fraction in this setting in patients who are not good performers, who do not have very long to live. Single fraction radiation, in conclusion, should be utilized more for uncomplicated bone metastasis, provides equivalent palliation in the same time frame for the same duration as multifraction radiation. Convenience, cost, and transportation favor single fraction regimens. Palliative relief usually starts in 2 to 3 weeks, but the full benefit is seen at 1 to 3 months. And I typically reassess patients at 4 to 6 weeks for response. Retreatment is safe and effective. And at this point, I'd like to thank you for your attention, and I'm always happy to have people reach out to me if they have questions. Take care.